Um, yeah, so thank you, Paul. So my name is Sam. I'm a PhD candidate with Paul in the Spatial Determinants of Health Lab. And what I'd like to do is contextualize our paper in the kind of broader research aim of our lab, which is reforming rural health systems. And there are certainly some inequities in rural health systems when it comes to access of healthcare for rural populations. And my doctoral research tries to address those inequities by finding better strategies to implement electronic health in these systems. So one of the priorities of our lab is to build resilience in rural health systems, and we do that by using a strengths-based approach. Resilience is important at the system level, and we cautiously recommend it at the individual level. And there's certainly some challenges in researching and working within rural health systems, but that shouldn't exclude them from the policy pipeline. I think that the research that is done in rural health systems should eventually be reflected in policy that governs them. This idea of policy being tailored to the place it governs is the foundation of a paradigm known as place-based health. And this is a rural health systems framework that we sometimes reference in our lab, and it's derived from these meetings with rural residents and practitioners. And rural health system reform would be built upon the foundation of rural traits such as frontline ownership, collaboration, volunteerism, altruism, and anti-fragility, which I'll discuss a little bit later. And the themes are some of the considerations and priorities of these rural populations as to what they would like to see changing for their rural health access. So, of course, access is a big one. Connectivity is another one that would support access, flexible roles and provider roles within the community. Group membership and education are all themes that we've extrapolated from our consultations with rural communities. So building on these themes and these rural traits, you would eventually have a holistic and equitable rural health systems policy. So to circle back to place-based health, it's a priority of the Canadian Medical Association. They've listed it as a priority for a goal for them by 2040. And one of the goals that they have is to increase this place-based health and idea and diffuse innovative care models can help to implement that. And so my research focuses on how we can better introduce electronic health into rural communities, because I believe that electronic health, again, can supplement both the place-based health policy initiative as well as contribute to the diffusion of innovative models of care. That's the CMA signaling its importance. So according to the CMA, they'd like to build integrated community-based care delivery models, which are co-designed by patients, caregivers, physicians, and other healthcare providers to ensure access to quality care. So certainly a lofty goal, but there is recognition that patients need to be a key stakeholder when we talk about rural health system reform, and their ability to influence how we discuss, care delivery and access needs to be prioritized. And a way to do that is introduce e-health. So we conducted a scoping review pre-pandemic about attitudes toward electronic health integration. And the attitudes were positive, both from providers and patients regarding electronic health. And there's certainly some potential and promise of e-health implementation in rural communities to address some of the access inequities that we've seen. So, of course, as was mentioned, during the COVID-19 pandemic, we saw implementation of e-health at speed and at scale, which previously would have been impossible to consider. And the reality was the tension for change was simply too high to ignore. It was either adjust your, models of care and delivery of care, or completely shutter them. So many communities and institutions took on electronic health initiatives with no other option. But given that, Canada still has a problem with healthcare innovation that's well documented in a federal report. known as the Naylor Report, which discusses innovation in Canada and has been labeled this nation of perpetual pilot projects. So there needs to be a strategy to maintain this innovative techniques that we saw during the COVID-19 pandemic and facilitate further innovation to bring about this place-based health rural health system reform. My research really focuses on the role of organizational change and principles to supplement and aid that. So part of fostering innovation is ensuring that your organization can actually manage change effectively. And there's many theories about organizational change. Most of them derive from business and finance literature. But the one that aligns with our view of change is emergence as a continuum. And that's in contrast to this idea that change is an incremental, small-scale, step-by-step process. We think that in healthcare organizations in particular, right, these very highly regulated systems, compared to maybe a Silicon Valley startup, there's the emergence is probably a better model for change as a continuum. So to help manage these emergent changes and to address this perpetual pilot project problem, there has to be a change in the way that we design our electronic health initiatives for implementation in rural communities. And the key research aim of my doctoral studies has been looking at anti-fragile design, where entities can gain stability through uncertainty rather than lose integrity. And I think anecdotally, we're all familiar with the high levels of uncertainty in implementation in healthcare systems. So it's an intuitive principle to apply to implementation process. So a lot of text on the screen, but just focus on the leftmost column. So tangibly, what is an anti-fragile design portfolio? And there's 5 operators that you can build into the design of your eHealth projects to increase the likelihood that they can scale and sustain to other contexts. So the first is optionality, and that's simply the ability of providers and patients to make choices with regards to how they interact with an intervention. And that interaction is key because it's through the use and utilization of an intervention, in this case, an eHealth project, that we understand which components of an intervention are core to its function and which are peripheral and can be changed from context to context. So without the use and utilization of a project, it's difficult to understand exactly what needs to be changed to reflect the realities of the context it's being implemented into. Nonlinear evaluation is this idea of trying to resist the urge to label something as a success or a failure. And that's really to monitor the unforeseen consequences of implementation. Certainly there will be a theorized impact of an intervention on outcomes, but there's also can be some surprises during an implementation regarding perhaps some outcomes on the system that were not foreseen. So nonlinear evaluation recommends surveilling the entire system to try and understand what the implementation actually impacts. Hybrid leadership is having both bottom-up influence as well as top-down influence on implementation direction, and that's the very perspective of the intervention's effects. Starting small is pretty self-evident. It's just limiting your implementation to small-scale implementations to allow you room to tinker and iterate as you go. And then avoiding sub-optimization is avoiding the maximization of efficiency of one aspect of the system at the expense of another. So an example of this would be, a state-of-the-art virtual health room at a regional hospital, but then very poor latency or broadband infrastructure in the rural practice that it connects to. So even if you have some very technologically advanced tools, if the information that these tools are gathering is arriving piecemeal to the patients that need it, it's a moot point. So those operators, if you incorporate them in the design of your eHealth project, can improve the likelihood that it scales and sustains. But how do you actually measure them? And now the two other outputs of my doctoral research in the anti-fragile design portfolio is this organizational readiness tool and evaluation framework. So the organizational readiness tool is the composite design cycle theory for organizational readiness for anti-fragile project deployment. Quite the mouthful. I just call it the CDCT to keep it simple. But it's based on the realist model of an intervention. So under this model, every intervention is some product of its context, mechanism, and outcome. And the CDCT is a collection of 6 recommended qualitative methodologies and research designs to help articulate the tacit knowledge and sometimes abstract concepts that really are relevant to e-health implementation in rural communities. So in order for a organization to deploy an anti-fragile approach, it depends on their ability to, or an anti-fragile project, pardon me, it depends on their ability to inform, influence, interpret, and then iterate throughout an implementation process. And as you can see, each stage is associated with the context, mechanism, and outcome of the intervention. So, informing yourself of the context, influencing the mechanism of the intervention, interpreting your outcome data, and then iterating the process is the structure of the CDCT. And the reason why qualitative methodology is recommended, especially in rural implementation, is because when you use quantitative approaches, sometimes the associations and relationships you draw from them in rural communities can be incomplete because of small sample sizes. So qualitative methodology is really powerful in providing some rich descriptions of these environments and implementations, and can give you information that would otherwise be difficult to obtain through quantitative approaches. So at the iterate stage of the implementation process, that's where you can apply the second output of my doctoral research, which is this matrix of sustainability and scale. And it's based on a meta-synthesis of the scoping review we did previously. And the way you would apply it is through a documentation analysis supplemented by mixed methods data. And after your first implementation cycle, you would then apply this tool to understand the direction and lessons learned from the previous implementation. And depending on where your project falls in this matrix, you are then kind of given some prescribed some protocol for how you should proceed for the next cycle of implementation. So for example, if your project landed in quadrant A, where you have high values of anti-fragility but minimal institutional investment, that's a sign that your intervention needs to signal its value to the institution in a better fashion. That could be through maybe a more detailed cost-benefit analysis by enrolling a champion into your intervention, or by aligning your intervention with federal, provincial, or even local policy priorities. But regardless of how anti-fragile your project is, if there's no institutional buy-in, your project probably won't get very far. Conversely, if your project lands in quadrant D, pardon me, where you have strong institutional investment but a rather fragile project, that's worrying, because I think anecdotally we can all think of a project that perhaps didn't have the impact on outcomes that it was thought to, but because of sunk cost and throwing good money after bad, path dependence, etc., the implementation was carried out to the bitter end to the benefit of almost nobody. So recognizing and realizing that you have strong or even priority investment for your project, but it perhaps isn't as robust or anti-fragile as it could be, is important. So building in some optionality or evaluating your project in a more nonlinear sense, etc., could aid in its strength for the next implementation cycle. So I'm always reminded of this quote by George Box, who was an English mathematician: "All models are wrong, but some are useful." Those two models I just presented are, of course, simplifications of very complex and complicated processes, but are important as reference points, especially when it comes to rural implementation, simply because there's not a very robust body of literature about rural implementation. And this is a good place to start. And if I could just circle back to the discussion about change management, there's a theory for organizational change that the most innovative practices exist in this poetically termed edge of chaos, which is just before complete chaos and just after complete stasis. So, I think it's pretty intuitive to recognize that an organization that is stagnant and very stable loses the ability to adapt when there is stress, but an organization that is very chaotic can also just risk complete breakdown. So, in a highly regulated system, how do you really bring about this edge of chaos environment needed for innovative practices? And I think, the anti-fragile approach can help with that by providing sufficient flexibility in how you use these rules. But they are still rules, and they bind teams to a simple rule set that will allow for diffusion of important information and knowledge about implementation, but also mitigates the impact of perhaps harmful practices. So all that said, e-health programs deployed using this anti-fragile portfolio approach stand a better chance of scaling and sustaining to other contexts. And in turn, this will address some of the health access inequities we see in rural communities. And I'd just like to close with this cartoon regarding, I think, an often reported but still understated consequence of this pandemic, and that's the mass exodus of healthcare staff because of COVID-19. And I think it's shown that the health system in its current state is untenable, and without significant reform, we'll continue to see headlines such as these, where there's a risk of entire provincial health system shutting down, 0 ambulances available in metropolitan Toronto, and ever increasing wait times in emergency departments and family physician offices. So, to summarize, rural health systems require reform to address inequities in healthcare access. E-health can address this inequity, but these projects really scale and sustain. And in tandem with that, innovation in being health organizations can contribute to this change. The anti-fragile design portfolio, so the CDCT and MSS, can provide implementation teams with complexity-informed tools for implementation in rural communities. And if they are deployed using these tools, then they have a higher probability of scaling and sustaining to address these healthcare access inequities.